Thank you for joining us for today's webinar, Integrated Treatment When Cognitive Impairment is a Factor. My name is Marla Kaufman, and I'm the Senior Communication and Health Promotion Associate at IRETA. I'll be moderating our webinar today. I would like to go over some quick housekeeping items about how to use the WebEx technology and how to access continuing education credits. And you'll also see that we currently have a poll open. So while we're going over these housekeeping items, if you'd just like to take a look at that poll. First, we would like to encourage you all to participate in today's webinar in a few ways. If you have questions for our presenter or are experiencing any technical issues, please use either the chat function or the Q&A panel to communicate your questions. Our presenter, Julia Brower, will take questions after the webinar. Feel free to submit your questions through the chat or Q&A box at any time. This webinar is approved for 1.5 PCB and/or NADAC credits, which are free. A certificate of attendance will also be available to download from your MyIRETA account. Please take note that it will take up to 48 hours for your CEUs and certificate to be available in your MyIRETA profile because we have to cross-check your attendance records with WebEx following the webinar. After the webinar, you will receive a follow-up email. This email will include a link to an evaluation form for the webinar, as well as information on how to access your certificate of attendance and continuing education credits. We may send you an additional email to remind you of the evaluation. I would now like to introduce today's presenter. Julia Brower, an advanced CASAC and NYS OASAS approved trainer, has dedicated her career to helping individuals with cognitive impairment overcome the challenges of addiction. Julia founded Dragonfly Consulting and Training LLC to help organizations develop strategies to increase engagement, enhance understanding, and support long-term recovery for people with CI in need of SUD or mental health treatment. Okay, Julia, if you are ready, I will hand things over to you.
Okay, I think I'm ready.
Great. Also, let me just close this poll. You'll have about 20 seconds to finish up if you're still working on it. And then I will post the results.
Okay, great. All right, I'm going to close it from my screen just so I can arrange things where I need them. There we go. Okay, so hi everybody. My name is Julia, and the letters that Marla spelled out for you in the state of New York, the substance abuse counseling credential is called the CASAC, the CASAC. And I'm also, and the state office is called OASAS, OASAS, Office of Substance Abuse Services and Supports. And I'm an OASAS-approved trainer as well. So here we are. And I know that integrated treatment is kind of a big buzzword right now, and that a lot of people are working for agencies that have either recently received funding or are applying to receive funding to create an integrated treatment environment. So I wanted to look at the issue of cognitive impairment as it fits in to the integrated treatment environment. So let's just jump in. This is where I would love to have be able to have a show of hands, or maybe if you can just put a brief like yes or no in the chat. How familiar are you with integrated treatment? Like, what exactly is it? What does it mean? And if anybody, like I said, if anybody just wants to throw a little, it doesn't have to be a paragraph. Oh, people are raising a hand. Okay, does that mean that you're familiar if you're raising your hand? Okay, great. I see a lot of hands coming up. All right, so I just thought it might be a nice way to start to just look at kind of the journey of treatment and how it has evolved into integrated treatment today. Okay, yeah, someone said receiving treatment for mental health and SUD at the same time. And that was the original intent of integrated treatment. It was really focused on dual diagnosis. So what we see here is, if you start on the left, we had our silos, right? We had our substance use disorder and our mental health and our medical, and they were all separate. And a lot of times people fell through the cracks because they needed both SUD and mental health. And the SUD didn't want to take them because their mental health issues were too much. And the mental health places didn't want to take them because they also had a substance use disorder, and they felt like they had to stop drinking before they could get help for their mental health. So, that's where we started from, probably in the 80s, maybe 90s, somewhere in there. And so the next thing that came along was collaboration. And I don't know how old everybody is, or like, it's hard when I can't even see you, but collaboration became a big thing, and there were these MOUs, right? And memorandum of understanding. And so the substance use would have an MOU with a medical facility or a hospital, and maybe they would also have one with mental health. But that was it. That was the oh, someone had trouble getting the link. Sorry. So the next iteration was the networks. And at one point, managed care companies were kind of requiring agencies to form networks. It made those sort of collaborations a much more formal arrangement, and they needed to have people from all aspects of a person's life, including, social services and vocational, and the H at the bottom is housing. So then you started to see these networks forming. And around the same time, we had some co-location happening. So maybe the county would put a substance abuse counselor in social services. So if somebody came in and needed help financially, or if they were applying for Medicaid or something, they could have a screening for substance use disorder, if that was a concern, and then they would get referred to treatment or whatever. So that's kind of how things, there was a lot of co-location with the jails and in social services, and even sometimes in other county departments where the general public might be coming in for assistance. And finally, we have true integration, and that is a person-centered approach for an individual or a family's total needs: medical, mental health, substance use, social services, housing, vocational, everything. I hate to say it, but it's kind of like a one-stop shop for all kinds of services that an individual might need. And so here we have our little clinic. It's all in the same building there. And this is kind of where we are today. Is anyone in the audience familiar with the CCBHC grants that were coming from the federal government? It stands for Certified Community Behavioral Health Clinic. And the idea behind the funding, yeah, I see a thumb going up. Uh, okay. In order to receive this funding, you are required to have all of these services under one roof. And the other part of it is, I mean, sometimes maybe the vocational or educational is not like in the office full time or whatever, but you have to have the ability to really connect people. And they have the concept of no wrong door. And by that, I mean, if somebody shows up and they need help, that you welcome them and you sit down with them and you figure out what kind of help they need. And if it's not anything that you can offer directly, you contact the correct place, the service that they need together, and you do the warm handshake. The warm pass, whatever it's called, pass off. You don't just give the person a piece of paper and say, okay, now you have an appointment for next month. It's like you get them to the next point as best as you can. So that's kind of where we are today. More and more traditionally behavioral health, and by the way, I hate that term, but SUD and mental health service providers are bringing in medical practitioners to be on site and vice versa. More and more medical facilities are bringing in mental health and substance use counselors to be on site. And so that's kind of where we're going. So there's several aspects of integrated treatment that I just wanted to touch on real quick. One is the actual physical building, the place, the location, the structure. Somebody said hiring duly credentialed folk. Absolutely. As much as possible, yes. So the physical aspects are not only like the building that you're in, but accessibility, location. On the bottom left, you see the hospital on a hill, and it's kind of removed from the community. And people who need these kinds of services are not necessarily going to feel welcome or even know how to access services in that hospital on the hill. So part of the physical aspects of integrated treatment is having the facility be in an accessible area, right in the neighborhood, basically. And also the accessibility in terms of, ADA compliance, actual physical accessibility to the building. And then another aspect, I mentioned the no wrong door. That's one of the sort of philosophical aspects of integrated treatment, taking into account the whole person and the family, if that applies. Sometimes people, by the time they get into treatment, they've pushed their family away, or their family has pushed them away. But sometimes you're talking about, a little nuclear family, right? Some spouses and children, and maybe a grandparent or something who all live together. So if that were the case, then you would want to take not only the whole person, but the family environment. And the other philosophical piece is recognizing the way that past experiences can impact a person, but at the same time, not focusing so much on maybe past, baggage or damage or whatever, but pulling out the strengths and building on the person's strengths so that I clicked. Anyway, so these are some of the providers that might be considered part of the treatment environment. Forgive me, I have to fix my mouse. Okay, there we go. So here we have, the traditional providers that you would think of when you're looking at mental health or substance use disorder treatment, right? Medical, dental, housing, primary care, social services, vocational. And then we have in the bottom left at about 7 o'clock, we have SDOH, which is the social determinants of health. And that's another one of those great buzzwords that everybody's using these days to talk about. Well, does anyone have a quick definition? How would you describe the social determinants of health? If you could just type something in the chat real quick. No takers. Okay. Well, I'm going to give it to you. All right. For some reason, my keyboard is not responding. All right. Let's try this again.
Somebody did respond and said access.
Access. Okay.
Environmental
factors. Yes. Anything and everything that influences. Yeah. Okay. So I love this little definition here, the non-medical factors that affect health outcomes. Yes, food insecurity, that's a great one. Because boy, what a huge impact on health, right? In every way, not just physical health, but emotional health. When you're always hungry and you never know if there's going to be food for your kids or for you, that's emotionally such a drain. So yeah, the non-medical factors that affect health outcomes, transportation, yes, very much so. So like the neighborhood, if you live in a neighborhood where there's great access to buses or, if you're in a big city, subways or whatever, if there's accessible transportation, that's golden. But where I live, which is kind of midway between New York City and Albany in New York, it's a much more rural environment. And there are some small cities and a lot of small towns, but within the county I live in, the bus service is extremely limited. So for people to be able to get to treatment or get to a grocery store, if they live in a food desert and they have to go across town or to the next town over to buy food, that's huge. All right, I don't want to spend too much time on that, but we know that we have to include all of these aspects when we're looking at the overall impact of integrated treatment. When we're looking at the whole person, it has to include all of this. Now there are the clinical concepts that I just want to, they're kind of guiding principles for integrated treatment, right? And right there in the center, you see the person-centered treatment. That is the heart, right? That's the heart of the treatment. And around that, we have the concept of complexity, the trauma-informed care, which we know is essential, and also cultural humility. That's another word that has kind of changed recently. We used to use the term cultural competence, but if I am not of a certain cultural identity, like obviously I am very white, so I'm not a person of color, I can't really expect to be competent in somebody else's culture, but I can have the humility to know that I don't know everything and there's a lot I can learn, and I can listen to the person that I'm working with and find out what aspects of their culture are the most important to them. So anyway, let's just take a look at those. Oh, there's a co-occurring systems of care. Has anyone heard of that one? That's another one of those. It's kind of the networking piece. Yeah, okay. Some people are familiar with it. New York State was doing a lot with this COSAC, co-occurring systems of care. And the idea is that, I mean, and if you've been in the field, you know this. We Years ago, we had to, when we were writing treatment plans, you know, we had to look at all these different aspects of people, right? But what's happening is over the years, people's lives have gotten more and more and more complex. And you see it in the treatment setting all the time. People are coming in with, you know, maybe like it used to be, you might find someone who only drank alcohol and that was really their only problem, you know, and they were able to keep a job and maybe they had some education or a trade or whatever, and things were pretty stable, you know, and you don't really see that very much anymore. So these are people and families who are characterized by complexity, and they tend to have poorer outcomes and higher costs of care. And that's really what it comes down to for the insurance companies, isn't it? Like they want to see the outcomes and they want to see us bringing the cost of care down. Now you'll notice all those little terms that floated by onto the screen. The one that's highlighted is cognitive and learning. It's not always mentioned. It is mentioned in this concept by, I don't know if yours is cut off. Mine is a little cut off at the bottom, but it's Kenneth Minkoff. He's done a lot of the training and just produced a lot of literature on the co-occurring systems of care. And he's one person who sees the importance of looking at a person's cognitive ability or their learning ability when it comes to treatment. And here we have cultural humility, cultural identity, and intersectionality. And again, here we are looking at all these different aspects of an individual. And this is nothing new. You've all been doing this. If you're a clinician, you've been doing this forever, especially around ethnicity, gender identity, military service. I mean, how many specialized services do we have for veterans, right? Socioeconomic status, sexual orientation, spirituality. These are all pieces that we have looked at, age, health beliefs and practice, all of it, right? Linguistic characteristics. And then there's ability. And I don't know about you, but for most people I've spoken with, when they see that term ability, they're thinking physical ability versus disability. They're not thinking necessarily in terms of cognitive ability. And that's part of the point of this whole thing, is that if you're really looking at the different cultural identities and the whole person that's presenting in front of you, looking at that cognitive ability is really important. And here we have the cycle of trauma exposure. We've learned that individuals with cognitive impairment, the rate of exposure to trauma can range from 49 to 100%. Now, that doesn't mean that all of these people are going to develop PTSD necessarily, but just in terms of trauma exposure, you're talking virtually 100%. And then same thing, very similar with substance use disorder, right? The rate of trauma exposure in people with SUD was 97% in this one study, and the rate of PTSD was 37%. So, you know, not everyone who experiences trauma develops PTSD, sorry, but the effects of trauma exposure can still have a negative impact on treatment. And I would say in some ways even more so, because if the person isn't aware that that trauma exposure had a lasting impact on them, they may not understand where some of their reactions or, you know, symptoms are coming from. They may be triggered by something that they're not even, you know, consciously aware of. And then we look at trauma and cognitive decline. People with high levels of PTSD symptoms experience significantly worse cognitive decline than people without PTSD. So this becomes the cycle, right? If you have cognitive impairment, you're more likely to be exposed to trauma. If you have a substance use disorder, you're more likely to be exposed to trauma. And people with trauma experience tend to decline cognitively faster than their peers who do not have PTSD. So experiencing trauma and PTSD increases the risk of cognitive decline. But if you're already cognitively impaired and you've experienced trauma, it just becomes that cycle. It just goes around and around. So what about person-centered care? That's one of those really important features, right? Now, I don't think anyone is not coming from a person-centered approach at this point. I don't know of any clinics or rehabs or anything that are not using person-centered care. So these are just, you know, kind of the basic reasons why this is important, because recovery is personal, right? Everybody is different. They have their own goals and needs, and one person is, you know, not going to be the same as the other. Another thing about person-centered care is that it gives the individual a sense of control and the confidence that they can make healthy decisions and learn to manage their lives. And it's not just that they have to follow what the counselor is telling them or the judge is telling them or the, you know, whoever is telling them. It's like they are taking responsibility for their treatment and for their decisions. So they become a part, much more active in their own treatment. And then, of course, in terms of that trauma piece, when you're looking at the whole person, the hope is that you can reduce those feelings of confrontation and judgment. You know, sometimes people are mandated to treatment and they feel trapped and they feel so defensive. And that whole process becomes re-traumatizing. So when you embrace the person as a whole and their needs and you know, validate their emotions and everything, it helps them feel a little more trusting, a little more safe in the therapeutic environment. So we see that cognitive ability is showing up in all of these factors. But does anyone have a guess of how much of a factor is this? What percentage of people do you think coming into treatment have some level of cognitive impairment? What would your guess be? 33, 90, 85, 70, 82. Okay, 50 to 75, 44, a third. Okay. All right. Try 80. Up to 80. The range is from in the 30s. Treatment and or education about, I'm sorry, that one went by pretty fast. But maybe that'll come up as a question later. So there was a study done in a detox in, I believe it was in Boston. And they did a cognitive screening on admission to the detox, and they found that 30 to 80% of the people coming into that detox had some level of cognitive impairment. A lot of it is temporary, you know, it tends to clear up, but not all of it. Some of it is permanent, and some of it is pre-existing, you know, somebody who had some cognitive issues before they ever started using. So factors like age, length and severity of use, the different substances you've used, all of that stuff plays a role in determining how much impairment, if any, the person is facing. So if you think about all the people if you work in a clinic environment, if you think about all the people that are patients at your clinic or your rehab or wherever you work, a good estimate would be around 50%, right? At least half of the people that are in your clinic have some level of cognitive impairment. And how does that affect their ability to gain from treatment? So here are some of the different types of cognitive impairment. When I say cognitive impairment or cognitive challenges, these are the things I'm talking about. So intellectual and developmental disabilities, obviously that's something that someone is born with, or it happens very early in life. It's pre-existing to the development of a substance use disorder. Same with a severe learning disability. But serious mental illness, we know, especially schizophrenia, the very severe level of mental illness can result in loss of cognitive functioning. Yes, somebody mentioned MCI, minimal cognitive impairment, as a precursor to dementia. And yes, we'll look at that in just a minute. Traumatic brain injuries. How many people with substance use disorders have been in accidents, you know, a car accident or a swimming, boating, any kind of moving accident where they've suffered a traumatic brain injury? And it doesn't have to be a severe traumatic brain injury. Yes, somebody said SUD's impact. And actually, there is, I didn't put it on here, but yes, if you think about somebody who's been drinking for 40 years, you know, heavily, what that does to their brain. Absolutely. And even like now we're finding with heavy marijuana use, lifetime heavy marijuana use, the symptoms mimic dementia. And it's hard to know, you know, because generally it's an older person that's been smoking their entire life. And so it's hard to kind of tease out how much of it is related to the marijuana itself, but we know that marijuana impedes learning. It impacts memory and that sort of thing. So yeah, long-term substance use can absolutely cause cognitive impairment, some of which unfortunately is permanent, and some may be temporary, or it may improve over time with treatment, with abstinence and treatment. Long COVID is a new one we kind of had to add in, because we're seeing people with, brain fog from COVID that can take months to go away, and sometimes, longer, or maybe it doesn't go away. And then we're looking at acquired brain injuries. And see, that's kind of where we put it in, to just to fit it in, we put prolonged substance use at the bottom. But we're also talking here about surviving overdoses, right? Opioid overdoses. I've had women in a group that I've run, and it's not just women, but I just can think of, like, there was this small group of women just sort of chatting before group started, and they were comparing notes about how many times they had been Narcan, or how many times they had overdosed. And that damage has to be cumulative, you know, um, depending on how long you were basically, dead, or your heart had almost stopped during an overdose before your Narcan. So yes, seizures can also lead to cognitive loss. So someone with a seizure disorder that has not responded well to treatment can experience a decline. But also, if you have a TBI, if you suffer a TBI that leads to seizure activity, that can increase the cognitive damage. That's very much true. So it's one of those, we're looking at the whole spectrum of cognitive impairment, right? We're looking at people who are born with challenges, who become more susceptible to develop a substance use disorder, and we're looking at people whose substance use or lifetime experiences have resulted in cognitive decline or cognitive impairment, or the serious mental illness. So this was, we were throwing out percentages, right? Go back. Why is this happening? I'm so sorry. We said 30 to 80% of people seeking treatment, right, have a cognitive impairment, and that line represents it's kind of the 30 to 80, right? Like, if that dotted section were blue, then that purple that's left would be the 30%, roughly. But look at the general population. People who do not have a substance use disorder or a serious mental illness, 12.8% of the general population. That's a huge difference. It's just, sometimes it's mind-boggling, even to me, and I do this all the time. So let's look at that 12.8%. People who are born or develop an intellectual disability make up 1% of the population. Long-term disability from TBI, 1.7%. Older adults, see, here's the MCI. Somebody put that in the chat. Older adults without dementia who have this mild cognitive impairment, right? So that's up to 7.2, maybe 7.5% of older adults have this mild cognitive impairment. And then there's people with substance use disorder or serious mental illness and cognitive impairment. And that's the low end. I only put the bar at 30 because if I put it at 80, you wouldn't be able to see the smaller amounts. So yeah. Is this surprising to anyone? Like, just looking at it in this way, is that a surprise to anyone, or is this something that you kind of knew? Not surprising. Okay. Anyone else? Okay. Yes, the percent may actually be higher. Where do folk with mental health issues land? In terms of cognitive impairment, I wasn't able to find as many statistics, but we do know that the different schizophrenia and other like bipolar with psychotic episodes or dementia with, I'm sorry, just depression with psychotic episodes, anything like that, the longer the person experiences psychotic symptoms, the greater the chance of cognitive decline. And TBI is much higher, 20% has had a TBI with lot. That's interesting. And yes, that may be possible. But in terms of like people who are so disabled from their TBI that they need help just to live is the 1%. That's like the long term. They're on disability from this TBI is a lower percentage. But you're right, up to 20% of the population has experienced some sort of head injury that resulted in unconsciousness. So again, it's like, even when you think about the whole concussion syndrome, there are so many things that can happen to people that can affect their cognitive abilities. And it's almost as if, oh, okay. Somebody just told me that the 1.7 is a CDC estimate that they no longer stand by because it's too low. Thank you for that. I'll have to try to find newer statistics. Okay. So why is this issue? Like, why do we care about this? If you're working within an integrated service clinic or network or facility, that's the word I wanted. Why is it important to recognize cognitive challenges as a factor when you're treating people? The basic reason is that people with cognitive challenges tend to have problems with things like learning, understanding, remembering, and or applying new information and skills. And what happens in treatment? What do we do in treatment? We teach people stuff. We want them to understand what we're teaching them. We want them to remember it. And we want them to be able to generalize the skills that we're teaching them in their daily lives. So the very things that we really need for people to be successful in treatment are the things that are impacted when someone has a cognitive challenge. And when I use the term cognitive challenges, I like to use that because not everybody has a diagnosis. Not everybody has made the connection that, oh yeah, when they were a teenager and they slipped on the on the pool deck and hit their head and they were unconscious for a few minutes, but then they were fine. They may not make that connection that they've had some cognitive issues since then. Um, and then if that person starts using substances, they may lose that thread completely. Like they may not ever think about the fact that that head injury might have something to do with their ability to learn or succeed in treatment. So, what do you think that's like for a person coming into your clinic? I'm going to give you a little taste. Now, if any of you have attended either of the two webinars I did last year, I used this. So don't give it away to anyone else. But imagine you're a patient and this is your first day in group and you're giving this handout. What's your gut reaction to this? What does that feel like? The rest of the group is talking about it, and the facilitator is like going over some of these terms, and everybody's like making the connection, like, oh yeah, wise mind. Oh, that's great. Like, but what the hell is this other thing? So anybody have any comments they want to share? Like, what would it feel like for you? Gibberish doesn't make sense. Someone would feel lost. Huh? Yeah, exactly. Anybody know what language these words are from? Confusion and probably not want to participate. Exactly. Overwhelming. Exactly. And would you want to admit to the other people in the group? Intimidating. Yes. Would you feel comfortable saying, excuse me, but yes, it's Swahili. Who knew that? Yeah, I'd stay quiet and sad. Right, checked out. I would have mentally checked out. Yeah, especially if I didn't want to be there. If I have some legal issues and they tell me I have to come to treatment and then I get this and I'm looking at it, like, you got to be kidding me. I'm out of here. Just mentally, like, just checked out. I would never have the courage to say, I'm sorry, but I don't understand these words. Yeah, shut down, not participate. I would never feel comfortable in a group of people or even one-on-one with a counselor. I would not feel comfortable saying that I don't understand this. Like, these words are too hard for me. I'm not that courageous. I'd be embarrassed. So I don't know how that person knew it was Swahili, but I spent my sophomore year of college in Kenya, and I used to be fluent in Swahili. So it was just, I figured it was a language that not too many people would know. But here's oh, nope, 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 nope. Oh, there we go. Sorry. Here's the English version. And this is the DBT Wise Mind handout that Marshall Linehan developed. So if you've ever been trained in DBT or experienced DBT in any way, you would be familiar with this chart. But uh, I always include this because I want people to really get that gut feeling, that gut reaction. That's what we're talking about for people. And how can we make treatment more welcoming for someone if this is the kind of handout that we use all the time? Okay. So in terms of, actual, I'm Eric attending from Kenya. How about Yako? Sorry. Um, so how does a cognitive impairment affect treatment? First of all, those mechanisms of change, right? Treatment engagement, adherence, insight, less readiness to change, increased denial, lower self-efficacy. That's what I was just talking about, right? Like you don't have the ability to speak up and say, hey, I need help with this. And so those mechanisms of change that are so um, those mechanisms of change result in a really high dropout rate, right? Less retention, and ultimately less abstinence, which is the goal, right? And in the mental health side, often there's, and even in the substance use side, there's less medication compliance. I hate that word, but like people don't necessarily take their medications. Learning disabilities can have similar outcomes. Absolutely. And that's why I included learning disabilities in that cognitive impairment umbrella, because if you're dyslexic or if you have a very severe learning disability, um, all of this stuff, working with written words can just be unhelpful, and stigmatizing. So, um, and in terms of integrated treatment settings, they're designed to be welcoming to all, right? Uh, and when you think about the complexity of the people who are coming into treatment, as you're all aware, you are likely to see more and more people with some level of cognitive impairment. And as I mentioned, the CCBHC, add communication through imagery in addition to written word. Yes, absolutely. I'm going to get to that. If you notice, like the earlier slides, a lot of them had diagrams and some imagery, and I tried to only have a few of these slides that are just, very text heavy. Art therapy, yes. But in terms of funding streams, there's that whole idea that you can't refer somebody out. You have to work with the people that come through your door, even if their cognitive challenges make it difficult for them to participate in group. You have to find a way to help them feel comfortable and included and welcome. And obviously, if there are safety reasons, you wouldn't have someone come into a group, but for the most part, it's like that no wrong door thing. Like you're committed to treat everyone. And on the positive side, if you are truly person-centered and you're personalizing the treatment for people with cognitive impairment, that's going to improve their engagement, retention, progress, completion, and long-term outcomes. So, boom, you by addressing this aspect, you have a very good chance of having a much more successful treatment episode for this individual and all of the people in your clinic. If you're really personalizing treatment, person-centered, right? Chances are it's gonna be have a very positive result. And again, you already have people in your clinic, right? Who you may not recognize have some impairment. So I want you to read this question. And I want you to think about people you've worked with. If you've been in the field for a while, I'm sure you've come across at least one person, but maybe more, who would fit this description. So I asked this question. This is a picture taken from a big poster board. I was at a conference last year, and I asked questions about working with people with cognitive impairment. And the first two questions were about, have you ever worked with someone with a diagnosis, like intellectual disability or TBI? And then the second one was, have you ever worked with someone who, didn't have a diagnosis, but you were pretty sure had some cognitive issues? And then there was this question. And it was called the STAR survey because we had people put stars next to their answer. And that's the answer we got. So if you've been around a long time, like I have, and you've come from the approach, the very rigid sort of AA oriented approach that was very prevalent 20, 30 years ago, where like you're treatment resistant, or if you don't comply, you're just not ready, or you don't want it enough. That's how people were treated in the past. If they just couldn't quite get it, and it being like the standard cookie cutter approach, if they couldn't get it, they were blamed. It's because they weren't ready, or they just didn't want it, and that breaks my heart. So I don't know how many of you have had that kind of experience, but it's so important to like broaden your perspective in the way you look at someone who's struggling in treatment. All right, so I know you have a bazillion things, right? You have all these old guard behavior modification, yes. Yes. Behavior modification, right? And the sort of therapeutic communities, the TCs, where like if you messed up, you had to scrub the bathroom with a toothbrush, or yeah. So here I am asking you to think about one more thing. And how the heck, like you're already juggling so many things, right? But this one, I think, can help make all the other ones a little bit easier. So I want you to think about the different considerations you have for other cultural identities, such as, where's my first one? There it is, LGBTQ+. What are you already doing for people who identify as, queer, gay, whatever it might be, trans? I know there's a lot out there, right? There's a lot of literature and research that's been done. So if you get a new client and they identify as LGBTQIA, using accessible language, yes. Inclusive language, yes. Respecting pronouns. I mean, it could be something as simple as that, right? Yeah, asking pronouns. And recognizing that this person's experiences, or using chosen names, yes, absolutely. this person's experiences in life maybe had a major impact on their concept of themselves, their self-esteem, um, respect how they want to be addressed. Yes. So like if you treat someone whose pronouns are, say, working for a tribe, we use two-spirit language. Yes, yes. So making it clear that it's a safe space and that you respect their culture, right? Their identity for what it is. All right. What about people of color? I mean, someone just said the two-spirit, which I love. I think that is so awesome. But what are some of the things you're already doing for people of color, for that help show that sort of respect, or taking into account their culture, their history, their experiences, their possible like generational trauma, right? I'm sure there's a lot of things you're already doing when you're working with someone of um, a different culture than you. I don't like to use the word race either. Educating myself on their, yes, specific cultures, religions, traditions, etc. Absolutely. Yeah. So you want to learn, right? You want to learn as much as you can about, and again, it's not about competence, it's humility, right? So you want to learn as much as you can so you don't like put your foot in your mouth, but you also want to be respectful and ask the person, like, what do you prefer, or how does this work for you, or what was it like in your family, right? And then the last one we'll do real quick. Again, it's those cultural differences, right? If you're working with someone, keeping the concept alive and in the forefront every day. Yes, being a student, I like that. I didn't get to read the last part, but so you get the idea, right? I don't want to I want to keep this moving. But so all those things you're already doing, right? You want to learn as much as you can about your client. What do they like? What do they hate? What are their norms? What's normal for them? What's normal in their culture or in their experience in life in terms of treatment? What have they learned? You know, um, what are traditions that that maybe their family, like if it's a person who was born with an intellectual disability, that can have a big impact on their beliefs and their values. But in the same way, if it's someone who has a TBI because they were driving drunk and they had a horrible accident, and they're dealing with the trauma, but now also they're dealing with this difficulty in processing all this stuff, right? So you want to identify the challenges that are particular to that person's identity, and we'll go through those. And you want to identify the struggles impacting their self-image, their self-esteem, history of being teased or bullied in school, family, all of that stuff, right? So on the outside, you may see a person with cognitive impairment may show some of these issues, right? Communication difficulties, maybe repetitive or stereotypic patterns of behavior, limited comprehension, absolutely, some social skills deficits, shorter attention span. Those are all kind of some of the visible things that you might see from someone, but you might not see these. So you might see things that are a little bit more subtle or not as easily identifiable, right? So someone with literacy, say someone is illiterate, they can't read at all. You may not know that, but you may see that they do not want to participate. They joke about themselves. They're embarrassed. They give brief answers that maybe don't quite answer the question. Or they may show some behavior that could appear to be manipulative, trying to get out of doing a written assignment, say. It may seem like they're trying to get over on you, which again, in that old school drug treatment kind of mindset, drug addicts are manipulative and they will always try to get over on you. I mean, that's where people were coming from, you know? And so you may see things that you're not sure. Are they trying to get over or are they having a legitimate problem, you know? And same with processing. So if you're in a group and somebody says something very deep, you know, maybe the person laughs because they don't know how to respond to that situation, or they take things the wrong way. Or this last one, responding to material covered previously after the counselor and the group have moved on. Why do you think that is? They finally, like, it took them so long to process that one thought that the group was talking about, that by the time they get it, yeah, it's a cognitive delay. Exactly. By the time they get it, the rest of the group has moved on. And so you may have someone in your group who emotional lability secondary to a TBI, yes, where the emotional response to a group situation is off. I didn't get to read the last couple of words, but yes. Okay. Now, again, there's this idea of behaviors, right? And, you know, disruptive behavior. But there may be some cognitive challenges, some impairment that's behind what appears to be a behavior problem. So shorter attention span, ADHD, like severe ADHD, interrupting, changing the subject, blurting out responses, standing up in the middle of group, you know, boundary issues. You may have someone who always sits outside the circle, you know, or you may have someone who has no boundaries and they're like on top of people and they touch people, or you know, all those kinds of issues. And the social cues issue is a big one because um, sometimes people aren't aware of their own body language. So they may be coming across as aggressive, but they don't think they are, or somebody else's body language may be puzzling to them. And the piece about concreteness, major differential diagnosis quandary. Yes, yes. So, and actually, I have included that in a slide before. Is it behavior or is it a cognitive impairment? And in the old days, the assumption was that it was behavior. And really, the heart of what I'm trying to present today is that that's an unfair assumption. You need to consider all the possibilities, right? If you're really committed to treating the whole person, you can't just assume that some unusual or unexpected behavior in a group is just because they're being disruptive for a behavior reason. You know, it may be more than that. And it's not fair to just make that assumption. So here, we're going to move into some like practical stuff. And I know I want to leave time for questions. So, but in terms of assessment, sometimes you have to be more direct than you would normally be with someone. Like if you're trying to ask a question and they can't really give you a clear answer, you may, in sometimes some people would think it's like a leading kind of question, but um you may need to do that to help them understand what you're asking for. Um, the biggest thing I can recommend is that you incorporate some sort of either cognitive screening in your assessment, or you use an expanded mental status exam as part of your assessment, because this is going to help you start from the very beginning, getting a sense how this person reacts and responds. So has anyone heard of the MOCA? It's probably the most well-known cognitive assessment. It's the one that I believe a certain president was given at one point. And anyway, but short of bringing another assessment into your intake process, if you can kind of expand your mental status exam, use a proverb. Like, what do you think it means if I say all that glitters is not gold? And you listen to their response. That's gonna tell you a lot about that person, right? If their answer is very concrete and they have no other comments about it, that's very telling. And the memory piece, and looking at, mood. Uh, sometimes mental status exams have way too many moods on it, and so you may have to like narrow it down. But still, all of those things. In terms of substance use history, uh, it, they may not have a very good ability to put things in order or remember the exact year. So you might ask about, well, were you in school, or had you stopped going to school when you started this? Those sorts of things. We'll show some more of those. In terms of mental health and medical history, you may not be able to get much at all. So you may have to rely on documentation, and that's one reason for requesting a detailed referral packet. With a mental health screening, if you do one, like, I don't know how many people use the modified mini, but you may need to adapt some of those questions, right? You may need to adjust the vocabulary or the references to time, the amounts and frequency, all that kind of stuff. Okay. So here, the DSM-5, right? That's a major criteria. And somebody was saying before about using visual aids. If you ask someone, well, how much did you drink when you first started, versus how much you drink now, or, it may be helpful to have like a picture of a can, and was it that can size, or was it a big one, a clock to help with time, or, the passage of time, right? So like in the beginning of the night, the person you might show a picture of a person who is dancing or something maybe, and then at the end of the night, the person is, face down at the bar, right? And the emotions and that sort of thing. So that's one strategy. Another one is to ask questions, like clarifying questions. Do you ever start thinking about beer or whatever their favorite brand is, or whatever, weed, whatever, and then you can't stop thinking about it until you get some? Because if you use the word like craving, they may not know what that means. They might, but they may not. So, asking those kinds of questions really helps people kind of boil things down or get to the heart of things. And then breaking things down into their smallest components. If you ask too complex of a question that covers, a period of time all at once, that may not work. And in terms of psychosocials, again, you want to get as much history as you can from people who know this person well. And not everyone needs this. If you have someone who's a great historian or whatever, then it's not as important, but that may be important. And the yes or no questions. If somebody doesn't understand really what you're asking, chances are they're just going to say yes or no. Like that's going to be their answer. They'll just yes you to that. So if you try open-ended questions and the person can't answer, you might give some examples, offer a couple of choices, and work from there. Over here with the relationships, it's great to find out, what is this person like? Who's important to them? Do they have a pet? Do they have a staff? Like if they live in some sort of like a halfway house or a group home, do they have staff that they get along with? What kind of hobbies? All that stuff, because you can use it to help motivate them in treatment. And then, of course, the literacy, life skills, all of those questions that are in the standard psychosocial, they're very important for people with cognitive impairment. And, your treatment plans, right? Are you just doing that old cookie cutter kind of thing? Or are you really making them person-centered? This was something I really wanted you to have in this presentation. I know we're running out of time. But you want to be welcoming to a person who's coming into treatment if you know that they have a cognitive impairment. Oh, I just want to spend a minute on this. I know we're running. I want to leave time for questions, but you know what? Maybe I'll just jump ahead. Think about the patient responsibilities that are listed, that are given to new patients, and think about what you expect of people when they come into a traditional treatment setting: attendance, punctuality, participation, behavior, all that stuff. Because are they expectations or are they hidden assumptions? That a person can sit in group for 45 minutes or an hour or a 3-hour intensive outpatient, reading and doing the worksheets or their homework, paying attention to movies, staying on topic, identifying and expressing their feelings appropriately, grasping material at the same speed as the rest of the group. Those are like sort of those hidden assumptions that a lot of us have. I mean, we all have, but maybe some of us are more aware of them than others. I don't know. But we have to become aware of those kinds of things. And the same with our expectations for progress. It's going to be slower. Chances are it may take longer. You may find that a person becomes very strongly attached to a staff member, and so those transference kinds of issues will need to be addressed. And this last one, lack of progress should not be a reason to discharge the patient, right? Like we know that now. But even for a person with cognitive impairment, they may not seem like they're making progress, and it just may take so long. But eventually, like if you keep working at it, they will start to show that progress. All right, so these are going to be included in your handouts, but these are just some examples of this one is vocabulary, right? And motivational interviewing. we know the principles and the techniques, but you may have to adapt some of those things, right? Language, cognitive ability, and those characteristics of staff. Cognitive behavioral therapy, what happened here? Emotions disappeared. That's interesting. Thoughts, behavior, feelings. Wow, that was fun. And you know how CBT is meant to be used, but there's a lot of things you can do to modify groups and individual sessions. And again, like this is not really the topic, this is not so much on topic for this presentation, but I just wanted you to have access to all this stuff. DBT, we know, is one of the most difficult ones, right? But there's this great book called the Emotion Regulation Skill System for Cognitively Challenged Clients. And I gave you the website. It is amazing. I use it with non-cognitively challenged people, and it's great. Thinking about things that are very abstract and how you can present them. And then, of course, trauma-informed care. Again, those last few slides were not really part of this particular topic, but I wanted you to have them. So I know we don't have a lot of time, but let's get to some questions.
All right, I think you did a good job at kind of answering them as they came in, but if anyone has
Okay.
any questions, feel free to submit them now. Somebody asked,
Oh,
what was the name of the book again?
it is called, nope, sorry, I'm going back. It's the Emotion Regulation Skills System. And you'll get these handouts. So it'll be in there. Important session and appreciate it. No mention of use of occupational therapists. Oh my gosh. If we had that luxury, I don't know if everybody could see that comment about using occupational therapists in this process. Gosh, that would be like the gold mine. I started out in special ed and I worked in teams that had PT and OT and all that stuff. And it is so, so helpful. So maybe when we're looking at integrated treatment, maybe that's something that can become a part of, you know, just a normal part of care for everybody. You know, so if you're going to this integrated treatment kind of place, and they think that you might benefit from occupational therapy, whew, that would be great. I ran a TBI, ABI, SUD system 40 years ago. Wow. Wow. That's awesome. I would love to speak with you about it or communicate. Working with adults with IDDs was my first job after college. Okay. And now you're doing this. See, that's kind of what happened to me. I got my bachelor's in special education and I worked mostly with adults. And then I got injured and I ended up moving into substance use disorder. And yeah, and then I had the chance to combine them. I actually worked at a place. Which type of medication can one, I'm not sure what that was. Oh, FASD. Oh my gosh, yes. Someone said it's important to mention fetal alcohol spectrum disorder, as it's now called, as a potential cause or source of cognitive impairment. Absolutely. That's under that umbrella for sure.
That other question was, which type of medication can one use to help treat or manage CI?
Oh, there's not really much in the way of medication specifically for cognitive impairment. Music therapy, yes. I don't know of any medication specifically for cognitive impairment, but medications that support sobriety or medications for mental health issues um, are helpful in the kind of broader sense that if the person is feeling, more stable mentally, um, can art therapy be used to identify or diagnose cognitive impairment? Yes, I believe. Um, is there a skills workbook for clients who don't read? Well, there are some things like you can find within AA, they have the 12 steps. AA has a little brochure called the Illustrated 12 Steps. And it's great because it boils down each step into a detailed picture and then a few words summary of the step at the bottom. And what I've done is I've had people create their own 12-step book. So we talk about the step and we get examples of how they can relate to that step, and then I have them draw a picture that represents the step to them, whatever that means. And I've had people that I've actually had to draw for because they couldn't draw what they wanted to draw. I've had people, many people, that I would write their comments as they were talking to me. And so that if they showed this picture to someone else and they wanted to share it with them, all of their thoughts would be on the paper, even if they couldn't write them themselves. So there are those kinds of things. The great thing about the emotion regulation skill system is that it's designed for non-readers to readers. There are symbols for every skill. There's a number that they use, and you can start at that level of just matching like the name of the skill, clear picture, to the image, which is the television screen, and so that book in particular was designed for people with cognitive impairment. Um, Many older adults are challenged with CI and resources are not easy for them to access. Yes. Yes. And so I guess that's my hope with integrated treatment is that fewer and fewer of these seemingly unrelated issues or, kind of extraneous issues will actually be identified and addressed so that people don't fall through the cracks, Anything else? As always, I wish that we had another hour. Once I get started, I can talk forever, but it's just because yeah, um, I really care about this topic.
All right. Well, thanks so much, Julia. If anyone wants to stick around for just a few more minutes, I'm going to go over some last minute housekeeping items. Thanks
Oh,
so much for
sorry.
everyone's great questions and for taking time out of the end of your day to attend this webinar. We'd like to remind all participants that a PDF of today's PowerPoint, along with a recording of today's presentation, will be uploaded to the webinar library located on IRETA's website. I want to remind you of our evaluation and CEU process. You'll receive one follow-up email from us. The first email will include a link to the evaluation as well as a step-by-step instructions on how to obtain CEUs. Please note that it will take up to 48 hours for your CEUs to become available. We would like to request that you fill out our evaluation. It should take no more than 2 minutes of your time. Again, we want to thank everyone for taking time out of your day to participate. If you have any questions, please email us. The email address is info@ireta.org. And with that, I will conclude today's webinar. Thanks so much again, Julia.
You're welcome. Thank you all. Alrighty.